Welcome to Micromed Education. I'm Dr. Archana Solanki, and today we'll discuss regarding the serology, in which we'll discuss various tests, which assets use, the method, their principles, and the test is used for the diagnosis of which infection, and briefly regarding few infective etiologies. So first we'll discuss regarding the basic thing that starts with the samples. So whenever there is in serology, what samples we prefer? Obviously a serum sample, that a blood that is collected in a plain vacuum tube. However, other samples which already we discussed in our previous video like CSF, urine or bronchoalveolar lavage can also be used for the detection of either antigen or antibody. Now in serology one has to remember generally the antigen detection we use is during the active phase of the clinical illness. One of the example is NS1 antigen, which comes positive from the very first day of the dengue infections. However, the antibody detection is generally recommended after the 1 week. Why? Because the body, it takes some time to mount an immune response and production of the antibodies. That's why it is recommended after 4 to 5 days. Now this is a picture of a microtiter plate. It has 96 wells and it coated either with the antigen or antibody. It is basically used for ELISA. Now what is ELISA? ELISA is enzyme link immunosorbent assay. It is basically an immunological technique either used for the detection or even quantify specific proteins, antigens, antibodies or hormones in the sample. Frequently asked question, which enzyme is used is horseradish peroxidase or alkaline phosphatase. It is used either for the antigen detection or antibody. Can be used for either antigen or antibody detection in both manner, qualitative as well as in quantitative. Now what are the types of ELISA? Direct ELISA, indirect ELISA, sandwich ELISA, competitive ELISA. In brief we will discuss. In direct ELISA, the antigen is immobilized and if antibody is present, that bind and get. In case of indirect, basically the antigen is immobilized and primary antigen that binds with the antigen and then enzyme link antibody will bind. It becomes more sensitive. However, in case of sandwich ELISA, there is a capture antibody which is immobilized and antigen from the sample it binds, followed by there is a binding of enzyme link antibody. So basically there is a sandwich of the antigen between the two antibodies. It becomes highly specific. And in case of competitive ELISA, the word itself suggests there is a competition to bind. So in this, a sample antigen competes with the label antigen for the binding with the immobilized antibody. It can detect small molecules and it is more complex and highly sensitive. Now these are the cards we have seen, either a black card or the white card. So basically these cards are used for the latex agglutination test. Now what is the principle of the latex agglutination test? In this, a latex particles are there which are coated with the gamma globulin, and in the patient serum, if they have an antibody, it will bind with them and there is a formation of a lattice or agglutination. That is called latex agglutination. So basically this black card is used for the diagnosis of CRP, RA or ASO because that these have a white agglutination, can be easily picked up in a black card. However, the white card is used for the slide Vidal test as well as RPR. One thing one has to remember here is RPR is a slide flocculation test rather than an agglutination test, because in this the precipitation it remains suspended in this in the solution rather than get precipitated at the down. Frequently asked question is, what is the difference between agglutination and precipitation? It is very easy to remember that the antigen is particulate in nature in case of agglutination, which is soluble in case of precipitation. As the antigen is particulate and the visible end product is clumps, in case of precipitation, it is precipitate. Agglutination can be visible in liquid, slide or plate, precipitation in liquid or gel. The examples of agglutination is blood grouping Vidal test, while in precipitation it is radial immunodiffusion. Now here you can observe the black card, the negative and the positive portion with the agglutination. It is used for CRP. Now CRP is used to detect and monitor acute inflammation. It is raised in sepsis, autoimmune condition and in trauma. The normal value is less than 6 mg per liter and it is a non-specific marker. RF factor is used for the detection of the rheumatoid arthritis. However, it is also raised in SLE and Sjogren's condition. So it is also considered as a non-specific marker and the normal value is less than 20 IU per ml. ASO is antistreptolysin O. It is used for the condition diagnosis of rheumatic fever, post-streptococcal glomerulonephritis, and it shows the evidence of recent streptococcal infections. And the its normal value is less than 200 IU per ml. Now here the white card shows a black color flocculation, and this is used for the test which is called RPR test. This is an RPR test. The RPR test is used for the diagnosis of syphilis. However, the frequently asked question here is, what is the difference between RPR and VDRL? RPR is rapid plasma reagent test and VDRL is venereal disease research laboratory test. Now both these tests are non-treponemal flocculation test. The point to be remembered here, in RPR a carbon particle enhanced antigen is used, which is easy to, because of that a black color flocculation is present which can be observed by a naked eye. The carbon particle is not used in VDRL, so you have to check the precipitation or in the with the use of a microscope. But the VDRL can be used from the CSF sample. However, RPR can only be done from a serum or plasma. However, a CSF VDRL is a gold standard for the diagnosis of neurosyphilis. Both tests can be used for a quantitative titer. RPR is basically a point of care test. VDRL is mainly used for the laboratory because it requires a microscope. Now, what is BFP? BFP is a biological false positive. This means the test is reactive even though patient does not have syphilis. So this happens generally with the non-treponemal antibody test, because here the antibody, it is cross-react with the cardiolipid antigen. And which are the condition which produce this BFP? It is acute infection, acute BFP, that is viral infection, bacterial infection, vaccination or pregnancy. And in chronic, it is due to chronic infections or autoimmune disease, IV drug abuse, and with the advanced age. So which test is required for the confirmation of syphilis? That are non-treponemal antibody test, a treponemal specific confirmatory test. So in this TPHA, that is treponema pallidum hemagglutination assay, fluorescent treponema antibody absorption test, treponema pallidum particle agglutination test, enzyme immunoassay, and dark field microscopy also use. But here the sample is the scraping from the lesion or the exudus from the lesion. Now syphilis has various stages: primary, secondary, latent, tertiary and congenital. So the timeline is also different. In the most important thing here to remember is primary syphilis, there is a chancre and non-tender lymphadenopathy. Chancre is generally genital. In secondary syphilis, there is a generalized rash is there with the condyloma lata in the genital region with the generalized lymphadenopathy. Latent syphilis, patient generally have clinical symptoms, but the serology remains positive. In tertiary syphilis, there is a gummatous syphilis, that is a granulomatous lesion in skin, bone and viscera. The two manifestations in this, a cardiovascular syphilis which has aortitis, aortic aneurysm and aortic regurgitation, and neurosyphilis has meningitis, stapes dorsalis, general paralysis of and optic atrophy. Congenital syphilis, that is transmitted transplacentally, and it has hepatosplenomegaly, bone lesions, and Hutchinson's trial, that is Hutchinson's disease, interstitial keratitis, and deafness. Now we'll move to our another card, that is white card. So we have already discussed in white card the syphilis or RPR can be done or a Vidal slide test. So here you can observe it is a Vidal slide test. But another test, that is Vidal tube test, that is frequently asked in our exams. So in Vidal tube test, you have to remember there are two types of tubes is there. A conical bottom tube, it is called Ray's tube. It is used for H antigen, H, AH and BH antigen, and flat round bottom tube that is used for O antigen. Why? Because O antigen clumps is compact chalky disc-like that can be observed easily at round bottom, and conical bottom tube has H antigens agglutination, which is large, loose and fluffy. O antigen is basically a somatic antigen. However, H antigen is a flagellar antigen. O antigen comes first and goes first, but H antigen appears later and sustained for a longer duration. The antibody titer significant for O is 1:80 and for H it is 1:160 in Indian population. The most important thing for the diagnosis of typhoid fever is BASU. The BASU stands for, in the first week of fever, you have to do a blood culture. In second week of fever, you have to do antigen detection. In third week of fever, stool culture, and in fourth week of fever, urine culture. Why? We have already discussed when there is an active infection, and in our previous video also we discussed a condition there is a bacteremia, you have to take a blood culture. It is an indication of blood culture. In first week of fever, in case of anthrax fever, there is an active bacteremia, hence blood culture is required. Bacteria are present in the blood and it can be easily picked up by a blood culture. However, antibody detection takes time. We have already discussed in this video that antibody takes 4 to 5 days. That's why Vidal test should be done in second week, and later on the bacteria will shed in urine and stool. That's why urine and stool culture is recommended. This is a picture, a slide showing a lateral flow assay. These are the cassettes you have seen. It basically have a sample port, and then you will get a different light either for the antigen or antibody like IgM, IgG and control band. What is the principle of this test is immunochromatography, and it is used for the diagnosis of various infections, bacterial, viral and even fungal. So basically HIV, malaria, dengue, hepatitis or typhoid IgM. This slide shows a cassette of HIV tridot. The principle here is immunofiltration. In both this rapid assay, you have to remember, if the control band or dot is not present, test is invalid. You cannot interpret the test. The frequently asked question with the HIV is, what are the mode of transmission? You have to remember it with its percentage of probability of transmission. That is 90% with blood transfusion, 20 to 40% with parent to child transmission. Sexual transmitter varies around 0.1% with different modes. IV drug abuser, it is around 0.5 to 0.1%, and NSI it is 0.3%. The HIV virus has affinity for CD4 T lymphocytes, and the co-receptors of there are CXCR4 for T cells and CCR5 on macrophage. HIV also, one has to remember the various stages, just like in syphilis we have discussed. So there is an acute HIV infection, then there is a clinical latency, then early symptomatic HIV and advanced HIV. The most important cells affected here is CD4 that we already discussed. Here the most common asked question is, which are the opportunistic infection related with the HIV? One has to remember various infections like oral candidiasis, bacterial pneumonia, herpes zoster, tuberculosis, hairy leukoplakia, and the most important one you have to remember with the CD4 cells. Like when CD4 cells less than 200, there is a probability of pneumocystis jirovecii, pneumonia, esophageal candidiasis, disseminated tuberculosis. With less than 100 CD4 cells, Toxoplasma gondii encephalitis, cryptococcal meningitis, and chronic herpes simplex infection. With less than 50 CD4, cytomegalovirus retinitis, Mycobacterium avium intracellular complex, and progressive multifocal leukoencephalopathy. The most important thing in HIV is laboratory diagnosis. As we discussed with any other viral infection, there is various tests, rapid point of care test, which will take time to be present, that is around 12 weeks, because it detects only antibody. The first test is here. It is a virus and there is a viremia. So the virus is present inside the blood. So it can be easily detected with only one test, that is a molecular test we have already discussed. So here the RT-PCR test is there that can be detected in 10 to 14 days. Then comes the antigen. Which antigen? That is P24 antigen. That comes within 2 to 3 weeks, followed by fourth generation of antigen, which detect both antibody as well as antigen, that is your P24 antigen. So it will become positive within 2 to 6 weeks. Then comes our routine testing, that is third generation ELISA, that comes within 3 to 12 weeks. And later on, within around after 6 weeks, around 12 weeks, it is point of care test, that is your HIV tridate or lateral flow assay. What is the window period? It is a time inter between the HIV infection and a point at which the test can detect infection. So if you use a point of care of your tridot, it will take around 6 to 12 weeks. But this can be reduced with the uses of HIV PCR, that is NAT, nucleic acid amplification test, they are real-time PCR, or P24 antigen detection. One has to also remember the NACO strategy for the diagnosis. So strategy 1 includes the blood bank, that is transfusion related. Strategy 2 includes surveillance diagnosis, and strategy 2 is for the diagnosis of the patients and includes this flow chart. What are the supplemental tests for the diagnosis of HIV? They are basically highly specific antibody detection tests like Western blot test. So how it differs from other tests? That basically in Western blot test, it detects individual antibody to various different type of antigen, as well as GAC, POL, NV genes product also. And another test is P24 core antigen. These are the supplemental tests. But which is the gold standard test for the HIV? It is viral RNA detection by either RT-PCR, NASPA, or branch DNA assay. One important point is DNA PCR. It is used for the detection of proviral DNA, and it is mainly used for the diagnosis of pediatric HIV, whether the infant which is acquired the HIV, which has HIV, or it is only the transplacental infection or antibody. We cannot roll out within 6 weeks. So for that, infection can be detected and confirmed with the detection of proviral DNA. And how it differentiate? It basically differentiates latent infection from the active viral transcription. Thank you so much.